We have another great session, a great panel here. I'm really very honored to moderate this panel of extraordinary individuals who recognized early on the challenges of COVID-19 and partnered with their local communities to develop highly effective responses that saved probably thousands of lives. We have Dr. Jian Zhang, who's the CEO of Chinese Hospital in San Francisco, who's going to present first. And then we have a presentation by Drs. Banh and Michael Peterson with the COVID-19 Equity Project in Fresno. And then finally, Carina Marquez and Susana Rojas from Unidos and Salud and the Calle 24 Cultural District in San Francisco's Mission District. And I won't go into long introductions because of the time, but we can hopefully they'll share who they are through their presentations, and we will have 15 minutes each, and then hopefully this time we'll have a little bit of time for Q&A, and both from me and from the audience. Thank you, and ready to have you go.
Thank you, Dr. Potter, for the introduction. Yeah, I know that time limitations, so I'll try to go through a lot. This is kind of really telling a story of Chinese hospital and what we did during the pandemic. So it's an hour presentation, but I'm not gonna do that. So, okay, so this, at the very beginning, January 2020, and so when we heard that there was an outbreak in China, in Wuhan, and so that's kind of when we got really nervous at that time, because we didn't know what COVID-19 was, right, at that time. So, and it was exactly like this time, and if you remember that in that year, 2020, and it was Chinese New Year was on January 25th. So people are going back and forth and all those. So when Supervisor Aaron Peskin and I toured the community, and so when we look at the, so it's for those of you who have been to Chinatown and to visit the SRO, the single room occupancy hotel, you would know, like the several one that we toured, and then 16 people shared one kitchen, one bathroom, one shower room. How do you social distance them, right? So despite of that, condition, that I found out that San Francisco Chinatown was the second most densely populated area in the nation. And then so with all those SROs and a lot of seniors and new immigrants and we had a lot of seniors with existing health conditions. So we knew we were at very high risk for a huge outbreak, and everybody thought that San Francisco Chinatown was gonna be the place for a major outbreak. And so we knew that we had to do something. I told Supervisor Peskin, if we have a major outbreak in here in San Francisco Chinatown, it would be a nightmare for you and me, because then, so we have to do something. And so a little bit history about Chinese hospital. And so Chinese hospital was established back in 1899. And it was, at that time, a lot of Chinese came to San Francisco not San Francisco, come to the United States to build a Central Railroad. When they were sick, they were not allowed to go to mainstream hospital. So that's why they built their own dispensary. And right after it was built, there was a huge outbreak of bubonic plague at that time. So that it was Tonghua Dispensary who took care of the community, because all they did at that time was the government built the ward to quarantine Chinatown. No one was allowed to go in or go out. That's what, so it stuck with the Tonghua Dispensary to take care of the community. Very similar during the COVID-19, that what we see, the anti-Asian hate crime and all the things that we experience is very, very similar, scary, 120 years later that we saw that happening. And so Chinese hospital apparently at this time is no longer just a dispensary. So we are actually integrated health system that we have our own health plan, have a hospital, a new hospital which was opened in 2016, and we have multiple satellite clinics. That's why during the pandemic we were able to do so much, because we have satellite clinics in different parts of the city. And then so we, during the pandemic, we actually edited more new services and new programs to help out. Like we elevated our ED in April to take more severe patients, and then we open up a floor to just help take care of San Francisco General Hospital's patient, so they could take more COVID patients too. And so we actually created a lot of new services. So this is kind of in Chinese, like crisis equals to danger plus opportunities. So we really focus a lot on the opportunity piece, like what we could do to safeguard the community again. And so we really, very quickly in January 2020, we changed our organizational goals. So we really said that at this point that we have to protect our providers and staff. That's our number one priority. So securing PPE was a tough task at that time, you probably all know. And ended up Chinese Hospital is the only hospital that our providers and staff didn't have to reuse N95. And so we spent 4 or 5 times higher the regular price to get them early on, because learning from what happened in Wuhan, and my classmates actually was deployed to China, to Wuhan to help out with, to lead a 52 ICU to take care of the COVID patients there. So a lot of information early on in January that I actually learned it from my colleagues in China. So originally I came from China. And so the other thing that would be to protect our patients and their families and safeguard our community. Now, we're a acute care hospital, right? So the public health work actually normally is not a hospital's job, right? But during the pandemic, any government agency or DPH can do it all. That's why that we knew that we had to step up to do the work. So we, that was our organizational goal change. And of course, there's a lot of challenges and really a lot of critical decisions I had to make at that time. And you all remember that shelter-in-place order was implemented on March 16. And after that, that elective procedures were canceled. That means what? No income, right? So you don't have money and you have to do more to safeguard the community. So that was really difficult. And then the shortage of PPE. If our providers are sick, guess what? Nobody can be there to take care of patients, right? So that's why, and that was really tough. I don't have time to go into how I created the pathway to get PPE. It's an amazing story, but we don't have time to go into the detail. So short of nurses and clinical staff at that time, so I think we all experienced that, lack of PPE. So that's kind of like really a lot of challenges there. And then I will share a little bit or like how we should do this partnership. And at the end, well, let me share this. This is our model. And so the COVID-19 management, the kind of the community model. And all of the talks before me, I think, really address that, right? How important it is to work together during the pandemic. So really, Chinese hospital took the lead, worked together with the city, DPH, and our elected officials, really, really supportive. And I just told you about Supervisor Paskin walks side by side, really that to make sure that we have the support, we have the police's support, make sure our employees are safe, and a lot of things that we work together. Our community partners, Self-Help for the Elderly, NICOs, a lot of other community associations working together, because they would, like Self-Help for the Elderly would deliver food, right? And then NICOs will have the staff go in bilingual staff going with us. Our staff providers and staff are all bilingual too. And so then we have the community leaders. And so it's very, very important to have the SRO owners or managers to work with you. Because if you can't get in, you can't do anything. There's one, I'm sure that it's not secret, and then 777 Clay Street at the time had an outbreak, right? Because the city was trying to get in, and because they had more than 3 cases, DPH was managing that. They couldn't get in, because they didn't know, they couldn't find the manager, couldn't find the owner. And so here, Chinese hospital, our board member, been there forever. They know exactly which building, who the owners is, so they'll go knock on the door, right, if they can find them. So that kind of community culture, you know, that you need that. The language piece, the cultural piece, is so important. So that's why, so we work with all those people. Now, another thing is the media. At the beginning, you know that we didn't know much about COVID-19. So that's why that what we learn, we talk to the media will go to the old Chinese media, they'll go to the community, they will tell them, right? So that makes a huge difference early on. So the model itself that we did a lot of early on education. A lot of prevention was done. So we actually went to the SRO and teach them how to wash their hands, how to clean the bathroom handles after they use, because they share a bathroom, right? Like 16 families share the bathroom, 16 people share the bathroom and the kitchen. So they had how to wipe, how to clean, don't go together to cook, and you know, all those things, like the details. And then we set up bilingual education materials, and then we also created bilingual hotlines, so they could do that. So all this model, I'm not going to go in detail to talk about that how we do testing, and then the contact tracing, all those, right? Then we support them when they're there, and then linkage care. So everything that's lead to that. So this model was adopted by the DPH later on, was disseminated to other communities with grants. So this is the timeline. I'm not going to go through that. You can tell that very early on, the second week, we held the February 1st, we held the community press conference to teach the community about the COVID, what they should do. So we actually did, this is the timeline, I can't go through that, and then we did we actually set up the mobile clinics to go to the community. They're so panicked. They really they won't come out, the senior residents. So we actually have to go to them. So we really appreciate the Stupsky Foundation that gave me $250,000 within 3 days after we requested to set up the first mobile clinic. So we could go to the community. You could tell that we did the testing, and then later on, our staff actually carry a pouch of the vaccines to go to the SROs to give them vaccines, because they were too scared to come out. So we managed more than 30 SROs to provide the vaccines or testings and all those things. So those are timelines, I'm not going to get into that. That's the other things we did. And so this is a comparison of the bubonic plague and the COVID-19 management, very similar, some of the things, anti-Asian hate crime, how we took care of the community. And so this is like how much we did. We open all our clinics as walk-in clinics, and in addition to that, we actually did the home visit to give the vaccines. That's why that we could reach so high. And we also, with the Postmus Square testing, we're still doing that. Again, with the culturally and linguistically appropriate care is so important. So that's why that we were able to reach the community. We actually serve in the entire city, the testing center. And so our vaccine rate was above 80% very early on. And so we were able to maintain as one of the lowest, one of the areas with the lowest infection rate. And that's rate for a long time, right? Like later on, we don't keep track anymore. But definitely by the end of the year, that we were still one of the areas with the lowest infection rate. Because of that, I mean, this is kind of the data from the city's website. And so the key factors to success is really early prevention, everything early. If you do early preparation, then that you do early testing, early linkage of care, early contact tracing, all those that lead to. And another thing is a collaboration. Work together, right? When we work together, we have more we have more power, actually. Everything work out better. So some of this is just the how we created a bilingual educational material or videos to show them how to use the testing kits and all those. As it goes, we create a lot more. Then those, if you're welcome to use, if you need to. And of course, everybody was surprised, right? Then why that Chinatown, everybody was expecting the huge outbreak and didn't happen. So the first article came out really from New York Times. Yeah, I got that. So that's, I'm not gonna go through that. If you want to do it, then a lot of the things to talk about, it's really telling the story, like over time, what we did there, and then how that we, of course, got a lot of recognition too from all levels of the, city, state, and the federal. I think I already covered the success and lesson learned. We don't need to do that anymore. And Chinese Hospital is actually one of the 2 4-star hospitals in San Francisco. The other one is our partner, UCSF. So that's why that we work together a lot with UCSF. We greatly appreciate UCSF's support, actually, because we couldn't do the PCR testing. We've used UCSF's lab. And the first 500 swabs that we used for the first SRO testing was supplied by UCSF. So we have been working together a lot already. Yeah, and then we actually, research-wise, then we doing a lot. I am a clinical professor for UCSF, so we've been working with a School of Nursing more. Now, one last thing I want to say that really that the community, when UCSF want to work with the community partners, it's great. I think that we would love to work with you again. That really that realize the limited resources the community has, really tight staffing. So you kind of like when you write your grant, it would be great to work with your co-PI first, so you can factor that in, right, to ensure the research success. Community typically that they would love to help you to work with you, but they have very, very limited resources. So I'm so glad that Dr. Tomas Aragon and Dr. Penn were here. And I think it's great for the government agency to know that too. We would love to partner with you, especially during public crisis, but we really need resources to do the work. So great, thank you.
Thanks. Well, thanks for the opportunity for Dr. Banh and I to present. So we're representing your regional campus in Fresno. For those of you that don't know about us, we've been a regional campus for UCSF for almost 50 years. We're founded in 1975. And what we're going to talk about is our role in the response to COVID-19 in Fresno and in the Central Valley. Do I have this as a slide? Good. So what I'm going to go over is to talk about the challenge for us and introduce you a little bit to Fresno County demographics, talk about the resources, the ask and the plan as we develop this, operations, evolution, and outcomes, and Dr. Banh, who led this project, is going to be talking about that. So the challenge, so since we're the only presenters, I think, from outside the Bay Area to talk a little bit about the demographics of Fresno County in comparison to San Francisco County. So our county population is slightly larger than San Francisco. We're just over 1 million population. We have a significant impoverished population. Almost 20% of our population in the county is below the federal poverty standard. And we have about 40% of the physicians per population that you have in San Francisco County. And this is a bit of the demographic comparison. We are a very racially and ethnically diverse county. As you can see, by far and away, the largest population group that we have in Fresno County is the Hispanic ethnic group. That's important, especially within COVID-19, because many of these people were essential workers in the food industry. They're the ones that kept your food coming during that period of time. Much as you heard in Chinatown, many of them lived in multi-generational housing, so it was very difficult for them to isolate after infections had occurred. And we also have a fairly large Asian population, we're one of the 3 largest areas in the country with the Hmong population. So where were we when COVID arrived? So it's a little bit interesting that the very first case of COVID in the Central Valley was in Madera Community Hospital, a town about 10 miles north of Fresno. That hospital closed because of bankruptcy 3 weeks ago because the cost of COVID care and traveling nurses and so on put them into bankruptcy. And here we are already with too few physicians, and we lost a hospital from this pandemic. At the time that COVID arrived, we have a very limited public health infrastructure in Fresno County. There were no PCR machines in the county outside the hospital laboratories, where obviously they were utilized for the hospital diagnostic study, so we had no capability for PCR testing within the county. The county had 1 mobile van for the entire county to be able to do outreach, and they had very limited sites for testing. And as I said, we had a high incidence of disease among the essential worker population within Fresno County. These were people that were predominantly residents in socially economic distressed neighborhoods. As I said, frequent multi-generational housing and minimal city and county resources in these neighborhoods. So with the arrival of COVID-19 in March, in May, I was invited to a meeting with the Fresno City and a developer in the community who was a large donor into our program. Asked me to meet with the mayor-elect, the mayor's chief of staff, and a community leader and UCSF Fresno donor to talk about, it was recognized that the problem was they didn't have enough resources or a plan about how to reach out to these essential workers and high-risk patients for getting COVID. They couldn't provide services to those most impacted regions in the city. They had federal funding coming, but they had no plan for how to use it. And quite literally what the mayor asked me at that point, if we gave you $5 million, what would you do with it? Now, this was not a thought exercise. You know, this was, we really have this check. What would you do with it? So we went through a conversation for the next hour, and what we did was to decide to build on the existing Mobile Heal program that Dr. Banh put together as a service learning experience for medical students. And they've been going out into the community to do events with farm workers and other small communities. We would expand the number of mobile vans and medical-grade RVs using this money so that we could reach out into the neighborhoods where the patient population was, and to identify fixed sites in the community which would be close to the most underserved neighborhoods. We're going to provide both fixed site testing and mobile testing events to reach the most number of people. We recognize the importance, as you've heard all day long today, about the partnership with community-based organizations to help lower the barriers to access for the populations at risk. One of the things we had to face very early on is those essential workers didn't want to be tested. They didn't want to be tested because they were afraid they're going to lose their jobs. And they were the only source of support for their families. So there had to be a lot of trust building and how we were going to handle that with them. We signed a contract with the city in August of 2020 to launch this program. And Dr. Kenny Banh assumed the role of director of the project. So what I'm going to do at this point is turn it over to Kenny to talk about the project and what some of the outcomes have been. Thanks.
All right. Thanks. Thanks, Mike. And I really appreciate all the speakers that have presented. It just is amazing what happens at UCSF, but at the same time, I always reflect on sort of sometimes a lack of resources or what we don't have relative down in the valley, kind of doing the work right in front of people. Just to clarify, I'm the Assistant Dean of Undergraduate Medical Education at UCSF Fresno, so run med student programs. I also am an emergency medicine physician and work in our safety net emergency department. So I don't work, while I started the Mobile Heal as an outreach project, this was like a part-time gig. You're looking at 1 of 2 people who are partly employed going out in the community with volunteers. And, sorry, I'm just trying to figure out how to advance. Going out to the community and then trying to turn around and do a response. So how do we go from basically taking an old ambulance, which was donated, going out to migrant communities and unsheltered and drug rehab facilities and doing primary care, urgent care connections to responding to COVID, what people needed. And it's amazing just listening to even like what Chinese Hospital did. Just to clarify, we have no hospital. We have no health clinic. UCSF Fresno is an educational arm that exists, trains residents and med students in partnership with other health clinics. There is no UCSF Health. We have no EMR. We have educational aspects, but basically we're the university arm, and that's it. So now we're expected to go take care of the entire region. I had to go hire about 60 employees. We created a network. It's great hearing about what you do in San Francisco with your community-based research, but this is the first time. We actually, at Fresno County, just created what's called FCHIP, which is a health improvement project initiative that work with CBOs. That's only 5 years old, basically just in its infancy, right before COVID hit. And that's not research, that's literally just for health projects, and research is gonna be a part of that. There is no research network. There is no community collaborative. All these had to be created from scratch. As mentioned, we have static locations. We go over to 50 different mobile locations. We started with testing, like everyone did. We knew vaccines were coming out, but we were asked, what do we do after that? What comes next? Medicines were changing, and we responded to many different things, including therapies for those who are actively had COVID. We started multiple different locations. Here's a look at Fresno City College. The demand was huge. We had no other providers in the region. Basically, we're it. The health systems and the hospitals actually declined doing public testing, essentially. They didn't run any of them in their public systems. They were overwhelmed, didn't have staffing. The physician shortages, the same with nurses. Nobody had them. So we were basically it in the region. We're the only place you could get free testing, free vaccinations. And there were small little other outreaches, but basically we had it. We had people camping out during the peak of both testing and vaccines. People would camp out in their cars the night before, waiting 6 to 8 hours just to get access into our system. We had lines that extend up to 2.5 miles long. We had police coming and shutting down our systems because we backed up the highway all the way up and stopped traffic for the next 2 miles, people trying to come in. We knew vaccines were coming out, and I don't want to talk about the cultural humility piece too much because a lot of other groups have talked about that, but we knew there was going to be hesitancy. We did spend time with our physicians and group to go out and work with community-based organizations to address questions, fears, responses, and these are civic leaders, elected leaders, religious leaders in different communities that we knew we were approaching, not just coming in as, we don't feel ourselves an ivory tower. We're a tower. It certainly is an ivory out here if you come out to the valley. You know, we're gritty and down in the ground, and we're very mission-based. But, you know, we wanted to make sure voices were heard and make sure that we were approaching the community with the appropriate cultural humility and making sure that we are effective in our care. What have we done? Well, you know, we went from an employee list of 2 to an employee list of 60. We still have no clinics. We still have no health system, and we are the largest provider of COVID services in the 8-county San Joaquin region. We provide almost 100,000 tests, all PCR. We gave out, closing on 100,000 vaccines. We've given almost 1,000 treatments to active COVID patients. We do not collect insurance. We do not collect documentation. We do not collect any fees for any services that we provide. We never have. So, thank you. There's some fun little stats. We've driven 23,000 miles just in the region, providing it all throughout the community. We were doing such a good job, the county says, once COVID numbers started going down, you know, they're like, okay, prep for vaccines. Oh, you're doing so good. Hey, there's an outbreak. Can you do MAB therapy? So we're like, I think I've got a kind of a loser or kind of a sucker on my forehead that I say, we got to do it. We got to respond, right? So, and then they said, hey, there's this thing called Mpox coming out. You know, nobody's doing that. Can you do Mpox? Oh, can you also give influenza for the homeless and the undocumented and unsheltered communities? And so it's actually been really great, but challenging. So we've advanced a lot. Challenges are, treatments are always changing. We have tons of RegenCov, if you remember the original MABs that are sitting in the fridge just out. We just this week parked our Evusheld. So treatments are still changing to this day. Like I mentioned, added flu, added monkeypox. This is a great start. We started this project as a response, and now we've built a lot of trust within our community, within the CBOs and the counties. And with that, we are building on that and past COVID and past this pandemic stage. While we're working on extensions for continued service in COVID, we've rallied that into, we just signed a $5 million contract with the county in order to provide general urgent care and transitional care, targeting rural and undocumented communities and essential workers. So we're moving out of just COVID and expanding back to the original mission of what UCSF Fresno is, which is training healthcare providers to serve our underserved communities. Thanks. In the past 2 years, I've been really fortunate enough to raise $22 million just for this project. That's from donors, grants, different community projects. We have a unsheltered project for a large transitional pilot where we're housing the majority of the county within one region now. And now they're gonna go to this transitional housing, so we'll be providing their medical care and transitional care. But it's not been without challenges. This is supposed to be a research conference, right? So we're supposed to talk about research, and I haven't mentioned research at all because darn it, it's hard to do, and in the setting of COVID, it was really hard. There was many aspects of it. One thing was funding. So funding was, we actually were given a lot of money, but the money really wanted to target clinical aspects. They really didn't want to do research. There was not interest from the community base. They were like, and in their defense, when I have a 4-hour wait to get into my clinic and I could hire workers, more people to vaccinate and do tests, it's hard to, how am I justifying pulling people off the line in order to do research in that? So that was difficult. We don't own our own health system. With that, we didn't own our own EHR. Our main hospital partner extended our EHR, but I don't have data access agreements for me to do research off that data. Same thing when we talk about our working with our CBOs and the county. The county wants to look at county public health things. I mean, listening to the earlier talks, it amazes me what you guys do here because we are nothing like that in the Valley. We are not just in the infancy of trying to get organized in the sense of partnerships across institutions, across CBOs, healthcare networks, in order to do such advanced data sharing. We're not there. We're not there, just truthfully. We get blocks with IRB. The IRB went to shutdown mode. They only approved clinical trials for a period where nothing went forward. So basically, if you did not do a clinical trial, and ours wasn't clinical trials, they were looking at access issues, looking at population space, we couldn't do that. And like I mentioned, there's a lot of continued changes. I really look forward to the project. And as we move from pandemic to endemic phases, we're not ending, but we're transitioning to involve COVID, but what else we can do to help serve our community. So thank you.
Hello, everyone. It is such a pleasure to be here today. Susana and I are going to, let me get this, so the outline for our talk is Susana and I are going to really tell the story of Unidos and Salud, which is a community academic partnership, and really sort of talk about the last 3 years. And then woven within this conversation is really, we're going to highlight some 3 themes or principles that really guided how we integrated research and service to drive action in the pandemic. And then we'll touch on next steps. So we got to start first with community. So I'm going to turn to Susana and tell us a little bit about the Latino Task Force and the beginning of the pandemic.
Good morning, everybody. So the Latino Task Force is an collaboration of 30-plus Latino serving organizations that came together to respond to the COVID pandemic in the mission. And now we've grown and we actually are responding in 3 different neighborhoods. So the Mission, Excelsior, and Bayview Hunters Point. The Latino Task Force, as soon as the pandemic hit and the city was closed, 5 of our community leaders got together and that we have to do something. So we were educating our community on how to stay indoors. We were noticing the need, economic need, and how many people were getting sick. However, we did not have the data. We did not have the capacity to do testing to really understand how our community was being affected by the pandemic, but we knew just from word to mouth or from seeing our lines in our foot hub that were going around blocks and blocks and blocks. And then
So just in the same neighborhood at San Francisco General, this is the view from the hospital, and this is taking us back to March. We're starting to see a lot of the first patients with COVID being admitted, and the disparities were very clear from the very beginning. From the first 157 patients, 80% were Latinx, majority from essential workers, and we knew that hospitalizations were just the tip of the iceberg. And I remember sitting in my office in Division of HIV/ID Global Medicine, Dr. Havler, who is a co-founder and really one of the brains behind this, said, we need to know what's going on in the community. And so with that, Unidos and Salud was born, I would say, probably at the end of March. And we actually, I think we have a shared motivation, and really we all, both Latino Task Force physicians and researchers at SFGH really noticed that the Latinx community was really very early on being heavily impacted by COVID-19, and we needed data to drive solutions, scientific insights, policy, and resources. So we formed a partnership, and it formed really fast. Some people say this was like a shotgun wedding. We had to learn to dance really quickly. And I think one of the key things about our initial connection was that via Jian Zhang, who's a nurse manager at our HIV clinic, who had long-standing ties to the community, knew many of the members from the executive committee of the Latino Task Force, and that initial trust helped us to kind of jump into this project quickly. It was a community academic partnership from San Francisco Department of Public Health as well, and California Department of Public Health. And our first project was looking at community prevalence, really trying to understand what's the prevalence of COVID 6 weeks into shelter in place. So in 3 weeks, we pulled together this study. It started April 25th through 28th. We did extensive community mobilization in one census tract in the mission for people who live and work in the mission, and then offered low barrier testing, no ID, no insurance. So you just walk up. It's quick, friendly service, and it's paired with a community-led response. And we ended up reaching 60% of the census tract, so about 3,900 people. And really rooted in this project was project co-design. We had community volunteer scientists all working side by side, each bringing their own expertise to the table. And then always important is rapid data analysis. COVID moves so fast, and communicating to the community first and policymakers after. This isn't a data talk, but I'll just sprinkle in a little bit data. And because I think it underlies sort of how we work. But from this first study, we really, we knew we were going to see disparities, but they were much higher than we thought. They were vast inequities. PCR positivity was 20 times higher among the Latinx community versus non-Latinx. We only had one non-Latinx person testing positive for PCR. The risk was higher for those who were unable to shelter in place. We gathered really important data highlighting that asymptomatic infection does happen, and then looked at used sequencing to look at transmission within households and the lineages in the community. I'm going to pass this to Susana. She's the brains behind this, but I think with testing, we knew testing alone isn't enough. We didn't have much with the response, but I'm going to pass it to you to share some about our test-to-care model and the solution.
So obviously, at the Latino Task Force, we already knew that people were suffering to eat on a daily basis. So if we already have that, and now on top of that, you have to isolate, you cannot go to work, you need food, you need the essentials in order to heal with dignity. And that's what this is. So it was someone comes up positive, then we call them, we do an assessment, and then we deploy couriers to take food and cleaning supplies to your home, and mask and PPE, so that you can stay home. You don't have to worry about where your next meal is coming from, and be able to heal and then come back into the community. Obviously, that is not always possible if the house is so dense. So we also had to talk to them about how to clean after themselves and how to make sure that you're keeping other people safe. And we were lucky in San Francisco that we have isolation hotels. So this team will do the referrals and make sure and fight, because there was a lot of fights that our colleagues will get into to make sure that people will get into the hotels. Because as the hotels were getting filled, it got harder and harder to put people into the hotel. So they had to really sell their case of why that person needed to be isolating in a hotel.
So I think that sort of illustrates theme one, and this has been a key priority for us, is data and scientific questions are rooted in action, community priorities, and holistically integrated with service. And here we've sort of outlined how some of the data has led directly to action. And Susana, I don't know if you want to comment on some of these.
And that was, so when Jian first came to us, so for us as a community, it's very scary to participate in a research project. Our community has been used time after time to do research, and then we don't know what's happening with that. And then oftentimes the results are not used for our benefit. So we were very scared to jump in, but like, we needed to do something. We needed the data. And with the first data, we were able to help supervisor run and write ordinance and legislation in which the right to recover passed, which now meant that people that needed to isolate, that did not have any sick time or any type of benefits, could stay home and they will get a base pay for those 10 days. That made a huge difference in the amount of people that were feeling more confident about coming and finding out if they were positive, because now they knew that not only they had food, they had PPE and cleaning supplies, but now they can isolate and not worry where their money was coming from.
So that was Project One, April 2020. Where did we go next? I think we did a lot of pop-ups, Transport Hub pop-ups, and I think one of the key things we noticed was that people were coming out to test, but when we were calling them, oftentimes they'd say, oh, I had symptoms like 7 days ago. And so we weren't reaching people fast enough to really jump in and do public health action and try to reduce transmission. So at that time, we knew that the rapid antigen tests were coming onto the market. This was before we all know and love these tests. But we thought, could this be the answer? Can we rapidly give people their diagnosis same day and jump into action? But I think this is theme two, which is really technology and diagnostics are really needing to, when you're studying them, using them, making sure that they advance community health, really extensive discussions with the community, and is this technology going to benefit them? And I think any quick words on sort of when we said, hey, what do you think about testing this new test on 16th and Mission?
We were, again, we were like, okay, we don't understand the science, but something beautiful happened through our collaboration is that we were always trusted that the scientists knew the science, and the scientists trusted that the community knew community. So we would come up with the plans and just trust that what they were saying. And honestly, every time that they came to us, there was no lies. Everything they said happened. So for us, it was very important that we trusted and we allowed the scientists to do the science, and that the community was allowed to do the community.
Yes. And I think there were some, we're not guinea pigs. Not too much into the data, but I think we did very extensive studies. We wanted to make sure this test was a good test, and really found that it rapidly detected most cases with transmissible virus, works in asymptomatic patients, works in all variants. We retested it with Omicron, and facilitates higher uptake of treatment. And this is just a graph of really showing November, December, when we used the Banh, and we were able to get people isolated a lot faster. Just speaking on technology, I think all of our samples, we do sequencing, and these are publicly available on our website and shared with the community. And before we did this extensive discussion, is this something the community wanted? And they said, yeah, we want to know what variants are here. Theme three, implementation science. What you do to measure what we do, to disseminate findings, highlight what works, what doesn't, and what's generalizable. These are pictures of LTF community wellness team members. So Susana, multi-component community-based vaccination strategy. We opened in February 1st. This is one of the most exciting days, I think, for all of us. Do you want to take us through sort of the strategy?
Yeah, so for us, it was important that any information that came to the community was in accessible language so that it wasn't scary, and that we were explaining everything as simple as possible as we could. So we were able to get information from the doctors, then we will translate it on how the community can gather it and understand it and take it in, and we would then share that information. And then for us, it was also important that we were motivating our community so that they can go out and be ambassadors and bring people in to get tested, to get vaccinated, make sure that we were vaccinating as many people as possible so we can curtail the infection, and then activate the community to be healthcare, not providers, but healthcare ambassadors that would share the message with everybody.
Yeah, so while you were doing your 15-minute waiting period, you would talk to someone, one of the community health team, and these are just some of the ways we measured these data. But people said, you know, yeah, this worked. People were vaccinated sooner. People said 90% reached out to one or more people about being vaccinated. 19% or more reached out to 6 people. Okay, so in closing, let's just talk about sort of this shifting landscape. Funding is changing, going away, and these disparities are still very pronounced. I think doing this work, the disparities in primary care access, chronic diseases, other infectious diseases really are clear. How do we continue to leverage what we've built and move forward? This is just sort of a quick place of like where we went. So in August 2021, we introduced multi-disease testing, diabetes, HIV testing along with COVID. We, in June, started offering Paxlovid on site, and then in the MPOX, the Latino community was extremely hard hit, and we're able to introduce MPOX vaccinations and sort of really thinking about a more integrated approach. These are just pictures of our on-site HIV diabetes testing and really highlighting that, yes, many people are undiagnosed and that primary care linkage is a critical piece that needs to be addressed. Less than 50% of people with diabetes had a primary care physician, and linkage, I will say, to primary care has been one of our hardest challenges. And then lastly, sorry, I'm running quick, I'm gonna get, within all of this infrastructure, ongoing investment into the career development of the community has been a top priority, whether it be pre-health students, we have mission language vocational students, medical assistant students who then are getting experience and then moving to full-time positions. We have fellows moving to faculty doing research, and I think this has been a critical piece. So where, in our last minute, where are we now? So we've done over 100,000 COVID tests, over 70,000 vaccinations. We've integrated multiple other testing, and it's always paired with the community wellness team support, as well as health education by our community wellness team, people we link to PrEP. We have a wide range of services. And COVID is still out there. 15 to 20% of people are testing positive at our site. So with this in mind, I think just quick things, we've integrated flu, RSV, really sort of thinking about this infrastructure to respond to new surges like MPOX, respiratory viruses, offering treatment, and then also really moving to expand our HIV testing. And then I'm going to just close. I think we have this site, very active, 24th and Cap behind the McDonald's, and sort of, Susana, sort of other visions for this site as we move forward.
So something that we were able to do was really bridge the gap in inequities and bring some kind of resources and healthcare to our community that often is very scared to access or has a really hard time to decipher how to access healthcare. So we want to continue that, not just for COVID, but for any other, whether it's another kind of big crisis or just regular, like come get your blood check, come get your HIV test, your A1C, because that little place has become the site that a lot of our community goes to when they have healthcare questions. So we're working right now to try to convince the city that they donate the space to us so that it can become a community space, not only for health, but also to bring equity in other areas that we're suffering in our community.
Thank you. And with that, many thank yous.